Guidelines 8 for the year 2025. Today is a very interesting one. I advise you to bring out your pens. It is in collaboration with Nigerian Society for Paediatric Cardiology, which is my home subspecialty, and it is my birthday, so it's all flowing. And if you know PAN, you know that NISOPAC is everywhere today. And they'll be talking about a very important topic, hypertension in childhood, guidelines and gaps in management. After now, the moderator, Dr. Lukemi Ige, will take over. But before then, I would like to welcome the PAN president, Dr. Ekane Mekure, the NISOPAC president, Dr. Wilson Sado, all our PAN elders here present and esteemed PAN member. Have a nice webinar. Madam President, over to you for your welcome address. Madam President, you're muted.
Thank you. So thank you very much, Madam PE, and happy birthday. We can see the birthday look already.
Yes.
So we can see that the party is loading. You have to send the cake to all of us. I know you're going to enjoy the day.
Yes, ma'am.
The IPP, Dr. Muride, the PAN Secretary, Dr. Chika Duru, other members of PANESCO in the room, the executive members of Nigerian Society for Paediatric Cardiology, ably led by my subspecialty society president, Dr. Wilson Sado, the moderator, Dr. Olukemi Ige, speakers of the day, Dr. Josephat Chinawa and Dr. Igoche Peter, PAN elders in the room. I could see Dr. Imabong Etuk and others, esteemed PAN members both at home and abroad. Good afternoon. As mentioned by the PE, today is an exciting day because, as you know, key people in this PAN executive belong to this subspecialty. So it's a very special webinar for us. On behalf of the Paediatric Association of Nigeria, I warmly welcome you to this month's webinar. We thank God for another opportunity to gather from different corners of Nigeria and the world. Our topic today, childhood hypertension, guidelines and gaps in management, is both timely and important. Many lay people and even some medical people unfortunately think hypertension is an adult disease, but as we know, more and more children are being affected by hypertension. In fact, trend data suggests that while prevalence is moderate, there is concern about increases in certain groups, especially in adolescents and with newer, more sensitive thresholds through guidelines. So the worrying part is that hypertension in children is often missed because many people are not checking for it. And when left undiagnosed and untreated, it can set the stage for lifelong health challenges. With huge gaps in Nigeria's school health program policy and implementation, this silent disease continues to thrive. This session therefore gives us a chance to pause, reflect, and ask, are we doing enough to detect childhood hypertension early? Are we following the best guidelines available? And just as importantly, what gaps still exist in our practice and health system, and how can we bridge those gaps? Please let's engage actively, share our experiences, ask questions. Let's learn from one another. Our strength as a community is in how we turn knowledge into better care for our children. A special thank you to NISOPAC and our resource persons for leading us through this discussion, and to all of you for making time out of your very busy programs to be here. Together, we're moving child health forward in Nigeria. I wish us all an enriching and interactive session. Thank you very much. So the moderator, you can take over from here.
Thank you very much, Ma. Permit me to stand on existing protocol. I'll still want to acknowledge the presence of Dr. Ogunide here with us, the PAN president, the PAN president-elect. Happy birthday to you. The PAN elders here present and everyone here. Thank you for being here today. Our topic for today titled, hello?
Hello, carry on, please.
Okay. Our topic for today titled Childhood Hypertension, Guidelines and Gaps in the Management will be taken by two very renowned pediatric cardiologists. We have with us Dr. Peter Igoche, who would start the presentation at this point in time. Dr. Peter Igoche is a pediatric cardiologist and an adolescent cardiovascular epidemiologist with more than a decade experience in tropical child health and multidisciplinary public health research. Presently, he is a medical manager of the Limi Children's Hospital in Wuse in Abuja. He obtained his Bachelor of Medicine, Bachelor of Surgery degree from the University of Nigeria, Nsukka in 2008, and a fellowship of the West African College of Physicians in Pediatrics in 2017. He also has a Master's of Public Health in Epidemiology from the Ahmadu Bello University in Zaria, and currently he's a doctoral research scholar in Adolescent Cardiovascular Epidemiology, School of Public Health at the University of Port Harcourt here in Nigeria. He's a member of various associations, including the Nigerian Society of Paediatric Cardiology, where he serves as the secretary of the academic committee. He's also a member of the American Society of Clinical Oncology and American Association of Cancer Research. He has over 40 publications in well-renowned journals. So we would listen to Dr. Peter Igoche, and then after that, I would introduce our second speaker. Dr. Peter Igoche, the floor is over to you, please. You have 20 minutes for your presentation.
Dr. Ige, sorry, I think we missed the address from the NISOPAC president, Dr. Wilson Sadu.
Okay.
So please, your
no problem. Sorry, sir. Over to you.
All right. I'd like to welcome everybody to this very important webinar. I'm sure Prof. Ige is in a hurry to leave. Thank you so much for bringing me on at this stage. I just have a few remarks to make. I'd like to acknowledge the presence of PAN and other PAN, president of PAN and other PAN executive here present, the speakers, and just permit me to stand on the beautiful protocol established by our dear president of PAN. But a few remarks. Hypertension is present in children, and there are clear-cut recommendations for children, especially those 3 years and older, to have at least their BP checked, especially when they meet us in the clinic. But unfortunately, it does appear that doing BP and thinking of hypertension, some of this that doesn't readily come to mind for us. And you would notice that the protocols are evolving to the extent that we now have a group of children that are practically treated like adults. And that's just to make it easier for us, since we often say that the guidelines for the adults are easier to deal with. But there's been several revisions, and recently another revision has been done. So we have some of the experts on the field to talk to us on the updates and some of the things that we need to do, probably haven't been thinking about. So I'd just like for us to relax and enjoy this webinar. Thank you all for joining. Professor Ige, over to you.
Okay, sir. Thank you very much.
You're welcome.
Yes, so I have introduced Dr. Peter Igoche, so he will take on from here. Thank you. I will let you know when you have 5 minutes left. Thank you.
All right. Okay. Thank you, my dear teachers and fellow pediatricians on this platform. I will be making a brief presentation on the overview of childhood hypertension. Basically, we'll start with the definition of what blood pressure is, and we know it's a product of cardiac output and total peripheral resistance. Now, in that definition, cardiac output is stroke volume times the heart rate. So in stroke volume, we are looking at cardiac contractility. That is the inotropic activity of the heart rate looking at the chronotropic activity, and the peripheral resistance. These three variables make up the blood pressure. Now, if any of the variables go up, the eventual product, which is blood pressure, goes up. So what is the definition of hypertension, being that we are not using the adult cutoff values? Now, for children between 1 year and 13 years, we have their category. And for adolescents greater than or equal to 13 years, we have their own category. So blood pressure is normal in children less than 13 years if the systolic and diastolic blood pressure are less than the 90th centile for age and gender. Now, but the values for the adolescents should be less than the adult values of 120, 80, systolic, diastolic. Now, from the older classification, which talked about pre-hypertension, we for this classification is now updated to elevated blood pressure, right? Then stage 1 hypertension, stage 2 hypertension. Now, systolic, diastolic, greater than or equal to 90th centile, but less than the 95th centile, that will be elevated. But above that, the child is hypertensive. Now, but if it's above the 95th centile, but less than 95th plus 12 millimeter mercury, getting the absolute value, is stage 1. But anything above that becomes stage 2 hypertension. We see that the values for adolescents 13 years and above are quite similar to adult values. When blood pressure is measured in the clinic, we have, permit me to say, we have two sides, whether we have two sides of the coin. We know that we are familiar with the concept of white coat hypertension, where the blood pressure reading in clinic settings is usually higher than the one done outside the clinic setting because of anxiety, possibly. Now, but the inverse is that with repeated measurements, we start getting lower values. But back to the white coat hypertension, when it is measured, is it really benign? Is it considered elevated blood pressure? Do we reassure them? We need to actually make this diagnosis because it requires follow-up readings done over a space of a few weeks, and then we get it. But actually, if we want to clarify the doubt, then it will be the 24-hour ambulatory blood pressure monitoring. But the accommodation effect where it gets lower could be due to the inherent variability in blood pressure, again, where ambulatory blood pressure monitoring is necessary. How do we measure blood pressure? Because it looks like in practice, we find different doctors do different things. Now, let it be clear that the upper arm auscultation is the basis for the reference we use, because use percentile charts and not absolute values. So if we have electronic monitoring, well, we keep it aside for now because we are talking of percentile reference values. We find in practice the wrist electronic blood pressure monitoring. Now, that is not really acceptable in pediatric practice because of the concept of peripheral amplification of systolic blood pressure, where we find that the further away the vessel, away from the heart, the systolic blood pressure gets higher. So the blood pressure is higher in the radial blood pressure monitoring than the arm monitoring in children. So our reference values are actually the arm values. Now, ambulatory blood pressure monitoring actually is more accurate than even the clinic monitoring. For children who we've made a diagnosis based on the table we had here earlier, ambulatory blood pressure monitoring becomes necessary. Still on blood pressure measurement. Now, we've said we keep aside electronic, except possibly those that have been diagnosed and possibly just want to monitor at home. But in clinic, the mercury sphygmomanometer is still being used. We know that the oscillometric method is gaining attention, and I think that will be handled by the next speaker. So auscultate using the bell and not the diaphragm of the stethoscope, the bell placed at the antecubital fossa. It is with the assumption that the palpatory method has been done, and then we get the palpate and locate the brachial artery. This look very elementary, but quite funny that these things are just done just haphazardly. Now, when we locate where the possible systolic from the palpatory method is, then we inflate the cuff 20 to 30 millimeters of mercury above that point, right? Then deflate at 2 to 3 millimeter mercury per second. The first sound we hear, which is a Korokov sound, is the systolic, then the fifth being the diastolic. Adequacy of cuff, because now this is a child, you have a child, a family with 4 children, one 13, the other one 9 years, the other one 5, and the other one 3. Now, we will not use the same kind of cuff for all of them. It is adequate if the bladder length is 80 to 100% of the arm circumference. How do we do that? It's assumed that we should have a tape that measures the distance between the olecranon and the acromion and the olecranon, gets the mid-arm circumference. So around the midpoint, the bladder, not the entire, like call it cloth, not the entire cuff, but the bladder itself should be at least 80% of the arm circumference, while the width at least 40% of the arm circumference. This follows a simple assumption from physics where the pressure equal to force over area. So if we use area of cuff that is too little, we'll get fictitiously higher values of blood pressure monitoring measurement. Now, blood pressure measurement with automated devices, we say it's not reliable because we don't have normative values for this in pediatrics, and the accuracy is really uncertain. When do we begin measurement of blood pressure? The NISOPAC president has just said it. We begin at the age of 3 years for some children, but for others, we actually begin a lot more earlier. For otherwise healthy children, begin at the age of 3 years and monitor annually thereafter. Now, for children who are obese, using body mass index percentiles, again, for pediatrics, the body mass index, not absolute values, percentiles. Those who are obese, those who have renal disease, diabetes, coarctation of the aorta, we start that early. But now, children less than 3 years, we have a special category. We are happy with the advancement in neonatal care. We are happy that premature babies are surviving now. We have centers where babies as young as 26 weeks are surviving, 25 weeks surviving. But that poses another set of morbidity in our hands. So babies less than 32 weeks, or those small for gestational age, or very low birth weight babies, should have their blood pressure measured much earlier than the 3 years that is generally put for others. Now, those with congenital heart defects, whether it has been repaired or not, should start it early. Renal disease, like recurrent urinary tract infection, hematuria, known renal disease or family history. Now, interesting that children with sickle cell should have their blood pressure measured earlier than even the general population of children. When we say hypertension, based on the classification that blood pressure is now above the 90th percentile, pre-elevated blood pressure between 90 and 95, then above 95 percentile, we say hypertension. Now, the etiology classification, primary or essential or secondary. When it is primary, we cannot identify a particular cause. So basically, we would have excluded other etiology that could cause the hypertension. But it is secondary when we can actually identify a cause, whether the glomerulonephritis, the pyelonephritis, obstructive. So a child that has posterior urethral valve should be monitored closely because it is a known risk factor for it. Now, renal vein thrombosis, cardiovascular disease like coarctation of aorta, which we'll look at very closely, patent ductus arteriosus, aortic insufficiency, then endocrine disorders, neurogenic disorders. Now, we commonly use non-steroidal anti-inflammatory agents. So it looks to me like the children with sickle cell have double tragedy because the hemoglobinopathy alone makes them at higher risk from what we just saw. And then because they have painful crisis, We use non-steroidal anti-inflammatory agents. So those who have it, it's a known secondary cause of hypertension. Corticosteroids and even drugs for we use to treat cough, nasal decongestants. Now, what is the goal of evaluation of hypertension? We want to distinguish between a primary hypertension and a secondary hypertension. We also want to identify any treatable condition that may be causing or contributing to hypertension. Also to identify comorbidities, because those who have chronic kidney disease, those who have obesity, those who have dyslipidemias, we monitor them as secondary so that we are able to identify and treat also. We also want to identify patients for whom antihypertensive medication is supposed to commence almost immediately. For example, those who have secondary or symptomatic hypertension without an associated risk factor amenable to treatment. So if I find a 13-year-old who has normal BMI and otherwise every other thing is normal, but is having a high blood pressure stage 2 hypertension, we will commence therapy immediately. We are not waiting. Now, any stage of hypertension with comorbidity, because the hypertension is there and there's a comorbidity, and those who do not fall into that class, for whom we would have started lifestyle change, like those who we know that obesity is primarily contributing, and they have actually commenced lifestyle modification but failed. They are supposed to. How do we differentiate between primary and secondary? We know that we have a barrage of investigations, which we will talk about, but basically from history, if the child is prepubertal, it's more common that it's secondary, is more likely in prepubertal children. Now, postpubertal, commoner primary. So secondary, prepubertal, commonly, rule of the thumb, but not necessarily absolute. Now, but isolated diastolic hypertension, more likely secondary. Nocturnal hypertension. So remember we talked about ambulatory blood pressure monitoring when there are variabilities. So for some, it's nocturnal and usually secondary. Now, those who have elevated body mass index, commonly primary, we know that it's primary, commonly is glaring. Now, if there's family history or there are symptoms, then it goes both ways. But this is just a vague classification. How do we work up children who have hypertension? If it is mild, usually asymptomatic, these children will not have any symptoms because it is asymptomatic, mild ones, maybe stage 1 elevated blood pressure. Now, this highlights the importance of accurate and prompt measurement of blood pressure, like we said, begin as early as 3 years of age. Now, but if it's acute severe hypertension, which may be symptomatic at presentation, we try to localize what caused it. For example, for acute glomerulonephritis, we may be able to pick history of headaches, dizziness, nausea, vomiting, irritability. Now, when there are associated neurological symptoms, we are able to pick symptoms of neurologic dysfunction like stroke, symptoms such as of congestive heart failure or renal dysfunction. These are presenting complaint. Now, when we go to review of systems, it's important to check, has it had any surgery before, any repair for coarctation of aorta, any history of obstructive uropathies that had surgeries done before, recurrent urinary tract infection. Now, medication history is important for corticosteroids, anti-asthmatic drugs, cold medications, aminoglycoside, cocaine use. These are important histories to get. Social history like smoking and consumption of excessive amount of caffeine, and family history. These are necessarily so important. When we come to physical examination, we will do what we generally know for physical examination, but in that, body mass index becomes important. Now, look at two extremes of body mass indices. Now, for those who are rarely obese, those with renal disease and have hypertension, usually secondary, and those who are obese could be because essential hypertension or from adrenocortical disease. So we find a child who is obese and hypertensive, we'll think very quickly what would have been the cause: obesity, essential hypertension, or secondary adrenocortical. Now, we look at the pulse quite closely because it's something we can all do. Are the pulses bounding in patent ductus arteriosus, or we have weak or absent femoral pulses where there's blood pressure differential between the arm and the legs, right? So in coarctation of aorta, there will be a clear difference. Now, normally in children, systolic blood pressure, we talked about the peripheral amplification of systolic blood pressure at the beginning of the presentation. So systolic blood pressure in children in the lower limbs is usually 5 to 10 millimeters higher than upper limb. But in the event it's reversed, we are able to say coarctation of aorta, even from just examination. Now, in our examination, we are still checking for end organ damage, like renovascular changes due to hypertension or cardiac heave, where the lowermost outermost point of maximal cardiac impulse is displaced in left ventricular hypertrophy as one of the end organ damages. It's also
5 more minutes.
Wow. Okay, it's better to look into the eyes of these children, which we will not look at this. Diagnostic workup, we see all of them should have urinalysis because you want to exclude renal causes, chemistry, lipid profiles, body mass index done, and other examinations to rule out endocrine causes. For specialized workup, echocardiography is important because that's where we claim the diagnosis of coarctation of aorta and left ventricular hypertrophy as an end organ damage that follows hypertension. Now, echo is supposed to be done every 6 to 12 months to identify end organ damage. Now, other specialized investigations for renovascular disease, ultrasound, computed tomography, angiography, and magnetic resonance angiography. For chemistries, we could have peripheral plasma renin activity assay is necessary because there could be hypertension with high renin activity and hypertension with low renin activity. Now, if there's high renin activity, we are thinking of renal parenchyma or renovascular disease, but more of the hyperaldosteronism if it is low. Now, this is more on the chemistries. How do we manage essential hypertension before the secondary? Usually, we want to start with non-pharmacological approach based on those we've excluded those who should actually start. So it's counseling, weight reduction, lifestyle modification generally. Now, the dietary approach to stop hypertension diet becomes important. This brings us to the fact that the management should actually be multidisciplinary with our nutritionists and dietitians being involved. But they look at the lifestyle modifications and the approximate change in blood pressure. If there is at least 10 kilogram drop in weight, the child is very likely to get 5 to 10% drop in millimeter pressure drop in blood pressure. Adopting of the DASH diet can reduce as much as 14 millimeters. And then every other one has shown physical activity between 4 to 9 millimeter drop. Right. So when do we start pharmacological intervention? When the non-pharmacological has become ineffective, like those with severe symptomatic hypertension, persistent hypertension, despite trial of lifestyle modification and all what we've seen. What are the choices? Initially, angiotensin converting enzyme, initial drugs, as we've seen. Please note that African American children do not have robust response to ACE inhibitors. So calcium channel blockers may be a better option, but when there are comorbidities like hypertension associated with chronic kidney disease, diabetes, proteinuria, then the angiotensin converting enzyme or angiotensin receptor blockers become important, right? We want to avoid diuretics and beta blockers in children who are at risk of developing diabetes, like those who are obese, because this affects the glycemic control. What are the drugs? Well, just briefly, we have a list of them, just to emphasize that not all drugs are safe at all ages. You will get these slides as we go on. Now, the goals of treatment, we want to reduce, if it is uncomplicated primary hypertension without end organ damage, our target is at least get it to elevated blood pressure, at least. But for any child that have end organ damage, or we known to have comorbidities like diabetes or chronic kidney disease, then we actually go less than 90th centile. When do we discontinue? Then we always ask this question. Do we discontinue a trial? A trial may be appropriate in children with the ones that are mild hypertension that has been controlled on single drugs, and lifestyle modification has helped a lot. For these ones, they will actually require ongoing lifestyle intervention and monitoring. We follow up with these investigations. For the secondary, we say basically looking at renal and coarctation of aorta. For renovascular, we do this imaging and follow-up. Angiotensin converting enzyme inhibitors, calcium channel blockers may be good for them. with less impairment of ischemic kidney. Now, surgical correction or endovascular revascularization may be necessary in those with renovascular hypertension. For those with coarctation, we see that it's when the patent ductus arteriosus is still patent, we find there is still flow. But when it fuses, when it atrophies, then the coarctation becomes real, right? For these ones, we realize that the systolic blood pressure in the upper limb, systolic is less in the lower limbs, whereas because of peripheral amplification, it should have been higher. For them, we could do balloon angioplasty, endovascular stenting, and end-to-end anastomosis. Then we ask this question in clinic: can I participate in sports? Can my child participate in sports? Well, if it is stage 1 hypertension that we do not have stage 1 hypertension, they have been evaluated and we've ruled out end organ damage, yes, no problem. But those with stage 2, there's restriction from high static sports, right? We will look at the next slide as we end. Classes 3A and 3 up to 3C are classified as sports based on higher cardiovascular demands, like we can see. So the one up here, field events, gymnastics, martial arts, no, boxing, cycling, no, downhill skipping, not at all, wrestling. But for lower cardiovascular demands, why not? So take-home message as we end is that proper measurement of blood pressure is a necessary skill for all medical practitioners who care for children. Remember that we use percentile charts. So we base on the measurements and height to get the height percentile in interpretation of the percentile charts, which unfortunately we are not able to do for time constraints. They are at-risk populations who require very early blood pressure surveillance, even below the age of 3 years, and it's important we know. So always rule out renovascular and coarctation because something can actually be done. We encourage all of us to have blood pressure monitoring charts handy, and note that in therapy, the goals differ, right? Those who are essential, less than 90th centile, and those, essential can go less than 95th centile for age and gender, while if there are comorbidities, it has to be less than 90th centile. Thank you for your kind attention.
Thank you very much, Dr. Igoche, for keeping to time and giving us that very engaging and insightful presentation. Our second speaker is a renowned pediatric cardiologist. He is Professor Chinawa, who is a consultant pediatrician and a professor of pediatrics at the Department of Pediatrics at the University of Nigeria Teaching Hospital in Enugu. He has won many awards, including the Mokolo Award of Best Performing Staff in UNTH in Enugu, the award also for Best Lecturer at the University of Nigeria in Nsukka, and also the Pan Adenike Grange Award for Best Researcher in 2025. He is a fellow of the National Postgraduate Medical College of Nigeria and a fellow also of both the American and the European College of Cardiology. He's a former Director of Research, College of Medicine at the University of Nigeria Teaching Hospital in Enugu, and is currently the managing editor of the International Journal of Medical and Health Development. He is also the current Vice President of the Nigerian Society of Paediatric Cardiologists. Apart from these accomplishments academically, he is also a senior pastor in the Redeemed Christian Church of God. He has about 250 scholarly publications in reputable scientific journals. Please welcome Professor Chinawa as he takes the presentation. Please, if we have questions for the first speaker and also for Professor Chinawa, we can drop them in the chat box and then we will take them at the end of the of both talks. Thank you. I hand over to Professor Chinawa, please. You have 20 minutes for your talk. Thank you. Hello, sir.
Hello, can you hear me from here?
Yes, sir, we can hear you now.
Let me share my slide immediately.
Yeah, okay.
Can I be unmuted?
You're muted, sir. We can hear you.
Can you see my slide?
Yes, we can. There's an echo in the background. Yes, we can. Please, let's remember to drop our questions in the chat box.
Okay, I'll just build up on what Peter Igosha has just dished out. So,
Professor Chinawa, we can't hear you. Can you switch off the second device? Thank you.
yeah. Can you hear me now?
Yes, we can hear you, but we can't see your slide.
Let me share my slide again.
Okay.
Can you see my slide now?
It's coming, I think. Yes, we can see it now.
Okay, thank you now. So I will just go straight to gaps in management for the sake of time. So we'll start by lack of standardized protocols for blood pressure monitoring and various conflicting charts in children. If you look at several studies in Nigeria, there are paucity and clusters of studies in the different states with different results. So there's a crucial gap in obtaining a nationwide chart of blood pressure monitoring from neonates to adulthood. A strong study protocol for developing local data on normative blood pressure is prime. This involves gathering comprehensive data from all the states. We can start doing that now from states. They get all the data and then have a composite value of this data to create accurate and reliable references. Why do we need to identify accurate values? Because accurate hypertension identification is crucial. Local data provides more accurate reference values for hypertension diagnosis. Population-specific factors can also influence BP. We must also have targeted interventions because understanding local BP patterns enables targeted interventions and public health strategies to prevent and manage hypertension. Utilizing ambulatory blood pressure monitoring is very, very important. Most of the thing we do here is office hypertension. We just measure it in our office and conclude. It can bring about some issues about white coat hypertension and mask coat hypertension. What is mask white coat hypertension? The patient may come to you out of anxiety, may have a high blood pressure in your office. When it goes out, the BP becomes normal. Or the other way around, he may come to your office and have a normal blood pressure. When it goes out, it becomes high, which is called mask white coat hypertension. So ambulatory blood pressure is important where the patient will have a BP in situ and be measured over 24 hours to know the actual blood pressure. Is a gap in management also. Collaboration and dissemination of information. There must be collaboration between healthcare professionals, researchers, and community stakeholders to enable us to have a good implementation of data utilization. And this involves sharing study results through publications, presentations, as we are doing today, and community outreach programs. This is also very lacking in our setting. Our communities and our health centers is not monitoring our patients that have blood pressure, and this can be missed. So there must be a kind of synergy between our health centers, primary health centers, and then the consultants and residents. There is no consensus on defining hypertension in newborn. Newborns, however, is also being somewhat neglected. There's no widely acceptable consensus on the standardized way to establish hypertension in newborns.
Very few works are done here in Enugu and some part of the country. I remember the patient I saw, a baby, it was crying, a neonate about 5 days old, crying repeatedly, restless, and very much irritable. The blood, the pulse somewhat, you cannot get the pulse, being a neonate, so we reached the heart rate. And when we now did checked everything was normal. But we did a blood pressure monitoring, we had a very small cough. And we had over 150 BP systolic, over 100 and something diastolic. And we did a renal ultrasound. Lo and behold, this child came down, had a renal artery stenosis. It was resolved and surgery was done, and the child is doing very well now. You see? So it's very good to have a high index of suspicion. And most of our newborns don't have their BP being measured. If it is not enter stage of meningitis, BP in newborn is very, very much important and should not be neglected. Hypertension in neonates has been relatively recently recognized and investigated as a distinct neonatal morbidity. Evaluation and management of this disease process was compromised by lack of comprehensive normative data for enteral blood pressure. If you look at the whole Nigeria, we don't have any cognate data for newborns, newborn blood pressure. We should start doing that from today to have a kind of nationwide study, which is a cohort that will bring out the BP of all the newborns right from day 1 even to day 28. How do we proceed on this? Neonatal blood pressure. This study must be done by taking cognizance of significant and rapid variability in BP with gestational age, postnatal age, birth weight, and gender. The selected population pose further challenges in establishing normal values and including definition of hypertension. We cannot have a national BP, hypertension definition for neonates in Nigeria as of today. What we have is different clusters of studies and different cutoff points without having a pool study. Even meta-analysis cannot even solve this. A cohort study is very important and prime. Randomized control trial is also very much crucial. There's paucity of study on detailed cohort studies or randomized control trial on left-hand cardiovascular consequences. No study or protocol on the effectiveness of neurological treatments and lifestyle interventions in children as of today has been done. So another gap here is that we must come together to bring out a protocol on the effectiveness of pharmacological treatment, as Peter has just mentioned, and then lifestyle interventions. It can be a mixed study involving both quantitative and qualitative study done over a long period. It will help us to enact or bring out a kind of pro forma or protocol for this particular issue. What about BP in children with congenital heart defects? This is another problem we are having in our country. You see, congenital heart defects in children also may come down with hypertension. People that have arterial hypertension, HOCM, that's hypertrophic obstructive cardiomyopathies, CKDs, and even left ventricular hypertrophy. It's important to also note that children that has congenital heart defect, even post-operation, may also come down with hypertension. It's important to note that hypertension is a common place in children with congenital heart disease. An urgent need. There's an urgent need for specialized pediatric hypertension clinics, at least a center per state. It will be very important. Regular blood pressure screening in children is very important for those who are at risk of blood pressure, of hypertension. So it's good to begin to have specialized clinics in our hospitals, which is not necessarily there. Is to have a particular day, we bring out as a clinic to look at children, or even go to schools to do a screening, nationwide screening for this particular blood pressure in children. Now, this is a study we did, Chinawa et al., between the age of 3 and 5 years in Enugu State. You can see that between the age of 5 years, this is the 5th centile, 90th centile. I'm coming somewhere. Then Papka et al. And my humble self did this study, and you can see that it's just from the age of 6 years to 13 years. Then Ujunwa Chinawa also in Enugu did for adolescents. You can see now. So what am I saying? There are different studies with different age group. There's no synergy. There's no constellation of figures to bring about a uniform spread or outflow of children with blood pressure. So these studies, you can see that different studies, different locations, different ages, different gender, I don't think it's the best. It's good to have a cognate value for the whole state and for the whole nation. Now, the European Society of Hypertension, the American Academy of Pediatrics, and Hypertension Canada define hypertension as repeated BP of 95%. I'm going somewhere. You see, these countries have already defined their hypertension. I want to ask us a question. What is Nigerian definition of hypertension for children, for neonates, and for adolescents? Is a question begging for answer. What is the guideline for the definition of hypertension in Nigeria? I want us to find out that there's ongoing debate about whether screening for hypertension in children delays its onset or improves cardiovascular outcomes in adulthood. You see, under a burner before us, a child who has hypertension, let me say at the age of 5 years or 6 years, do we follow that child up to adulthood to know if there's any correlation between childhood hypertension and adulthood hypertension, or any adulthood renal or cardiovascular abnormality stemming down to the particular childhood hypertension? You see, United States of America has done that, and they have, though certainly a lack of evidence to support this particular issue or this particular research question. But it's left for us to also do the same study in the different states or as a nation to get the BP of children that have hypertension and follow them up for about 15, 20 years and now know their outcome vis-a-vis their complications. They have BP in adulthood, any organ damage, and so on and so on, and even the effect of lifestyle changes and drug intake. Furthermore, the potential harms of screening must be considered. For example, those lower screening thresholds could result in overdiagnosis. So when we are doing screening also, we should be very careful to make sure that the child is not overscreened, because one may say, do we now get every child with any child as screened for blood pressure? The answer is yes and no. No, because we must have a very good history, very important history taking, because in pediatrics, history taking makes up about 70% of our diagnosis. So please, we should not throw away history taking in the name of trying to do blood pressure for all the children. There's gaps in the identification and treatment of hypertension in children. Threshold limits vary between guidelines, and the accurate threshold has to be determined. Lifestyle modifications are a cornerstone of hypertension management, but the optimal diet and physical changes for beneficial effect are not known. So we need to do a randomized trial. It may help us to find out if there's any clinical correlates between hypertension in children and then lifestyle modifications, very crucial, and that will help us a lot. Then the long-term cardiovascular consequences of elevated blood pressure is not even known. Studies are very needed because long-term cardiovascular consequence of elevated blood pressure is key. We don't know if somebody has a BP now. Do we know the long-term consequence? The cohort study is also lacking in this our country. So we should get together as PAN to begin to do all these cohort studies, having a cognitive blood pressure measurement, and having a kind of let me say a pro forma for our blood pressures among children. We must have our own Nigerian definition, not putting our trust in European, Canada, America. It's high time we came down to begin to bring about our own Nigerian version. Cohort studies also continue. For the cohort study on the long-term cardiovascular consequence of BP, the following should be done. Nigerian Society and PAN should be involved in writing a robust grant, enable us pool resources to begin this study. This can be done by forming committees and subcommittees on grant acquisition, which must be smart. There is a paucity of guidelines, especially in pediatrics. There is a dearth of hypertension guidelines in our setting, especially in the low and middle income countries. The available guidelines we know is not, we have in LMIC, of which Nigeria is part of them, is not in keeping with WHO recommendation. The available guidelines from low middle income countries are not unique. They were adopted from other countries. See, we just bring other countries' guidelines, modify it, and publish it. Please, it's high time we began to do something serious about this particular issue. There's also a very yearning gap in the choice of medications. You see, if I have to ask us now, PAN members and my humble self, do we have any guideline for treatment of hypertension, pharmacological treatment? The answer is not necessarily yes. So a time has come for us to do a study to know which drugs is good for a particular illness, a particular cause of hypertension in childhood. So there's a gap of medication is also lacking, as the place we must do a big study. There's urgent need for a composite regional guideline, as socioeconomic and socioeconomic structure and health policies of these countries may vary from region to region. Even the socioeconomic characters and demographic structure, we don't know about it. Like now in Enugu, we may say, oh, blood pressure is coming out with middle class. What about Oyo State? What about Akwa Ibom? What about Kaduna? What about what about Katsina? You see, or Adamawa? So it's good to know, to have a pool study, to know the effect of even socioeconomic and socio-demographic structure which is correlated with blood pressure in children. There's gaps on exploring genetic links with childhood hypertension. Another issue we have here is we know that out of every 3 children, 2 of them may have some genetic correlates of hypertension. Identifying genes and genetic variations involved in childhood hypertension is called genetic mapping. I know you may ask me, how do we go about this? I thank God that our PAN president is here, who have done genetic works in congenital heart defects. She's a living testimony. He has done a great work on genetic correlates of heart defect and presented in one of our NISOPAC meetings. I really benefited from that. So in the same vein, we can extend this particular idea to hypertension. You can do genetic mapping and to know if there will be any polygenic or genetic issue or nature that affect hypertension. When we can do that, then we can begin to look for a way to handle hypertension genetic-wise. Some of these research involve the following: genome-wide association studies, called GWAS, is very important. Family and twin studies, very, very important. Gene-specific studies, research focusing on specific genes, such as ACE gene and their role in hypertension. You see, there's a study that was done some time ago in Europe where they pinned down the ACE gene, which is adenosine converting enzyme gene, to be implicated in hypertension. And there's a common variation in DNA at a single gene position as a risk of hypertension. I think we should bring it out to Nigeria. We'll have to get a grant to sponsor this particular work about genetic correlates in hypertension. We also do a genetic loci and genetic risk scores. What is this ACE gene, otherwise called the angiotensin converting enzyme? This enzyme provides instruction for making angiotensin converting enzymes. It's a common polymorphic enzyme called an ID. So if you can locate this ID variant in this particular children doing genetic assay, we will now find out that this is a particular cause of hypertension and this can be prevented in the future. What is this ID gene? It is called the insertion deletion variant of the ACE gene. Ladies and gentlemen, I would like us to look at all this I've talked about, and let's give it a serious thought. It's important and it's high time we begin to come together to begin to form studies and groups and subgroups on how to put these particular issues at bay. Thank you very much.
Thank you very much for keeping to time. We actually have 5 minutes left from your presentation, so we are doing very well on time. Please, let's remember to drop our questions in the chat box. There are some questions already on the chat box. So we'll take the questions on the chat box, and then if there are any other questions or concerns.
These are my references, sorry. Link to our references.
Okay.
Yeah, thank you.
Thank you, Sam. So Dr. Igoche led us through hypertension, where he looked at the definition, looked at the causes and how to differentiate primary from secondary, and also told us about investigations and treatment. And then Professor Chinawa took us through the gaps in management of hypertension, including the need for more data and genetic mapping, how we need to have a high index of suspicion, and also our need for protocol guidelines. We'll take the first question here for Dr. Igoche. Where do we classify the hypertension in preterm infants, I guess? Is it essential or secondary hypertension? That's the first question for you. The next question is, which side of the arm is it best to take the blood pressure, right or left, and why? Dr. Peter, I think you can start with those two as I look through the chat box for other questions. Thank you.
Okay, thank you for those questions. Well, about preterms, we are happy with the survival rates of our low birth weight, very low birth weight, if our extreme preterms. The comment about blood pressure monitoring in them just brings us the fact that they are in a special category of children who should have their blood pressure measured earlier than the age cutoff of 3 years. Now, as to whether it is essential or secondary, we will need to exclude because, any child could have secondary hypertension from the list of causes that we looked at in the etiology. Any child could have it. If after evaluating that child, that NICU graduate, the preterm graduate that left neonatal intensive care unit, and we cannot find any cause for it, we could say essential. So it will be difficult to lump all of them and say every preterm graduate is that we find elevated blood pressure is classified as essential or classified as secondary. I mean, effort should be put in to identify what actually caused it for us to make that distinction. I would be happy if other thoughts can be put to that. Now, as for which side of the arm, conventionally, some guidelines prefer the left arm. And why? It is assumed just from deducing from the fact that from the left ventricle, the aortic root arises, the ascending aorta, then the arc, the first branch being the brachiocephalic trunk that divides into the subclavian and common carotid. So the subclavian that now extends to become the axillary on the right is not starting directly from the trunk, whereas towards the left side, where the subclavian artery arises from the aorta itself, it's an assumption that it gives a more reliable index relating to the heart. But however, it's just taken as a guideline anyway that conventionally we use left. As to whether which one is more reflective of the heart, the caliber of the vessel branching off may be one of the explanations. But then arm measurements actually should be on both hands. And when we find difference of greater than 10 millimeter mercury from both arms, then we monitor the patient using the one that has a higher value so that it tells us better about the control. And it's important to consistently use a given arm for consistency, for follow-up. Thank you.
Okay, thank you very much. Other questions for you? Does medical treatment have any role to play in the treatment of hypertension due to coarctation of the aorta? If yes, which drug should be used?
Okay,
Another
so
question.
Okay.
Okay, there are two more questions. Let me read them out and then you can take them one by one. Why is ACE inhibitor contraindicated in stage 4 and 5? I guess that should be stage 4 and 5 hypertension. And then most hospitals don't usually check the blood pressure. Why? Well, probably that wouldn't be your question, but yes, those are the 3 questions.
Okay, thank you. So for coarctation of the aorta, we first of all talked about the fact that it should be picked up early, and we could easily do that from our comparison of arm measurement and the lower limb measurement of blood pressure, and the concept of peripheral amplification of systolic blood pressure, where the diameter, the caliber of vessels gets smaller as they go further. So normally you have a higher systolic blood pressure, although the diastolic or mean arterial pressure does not really change, but the systolic gets more amplified as we go distally. But for coarctation, it is reversed. So in coarctation, we have it higher. So you easily find that. Now, in treatment, we talked about endovascular repair. We talked about end-to-end anastomosis. Those are surgical repair, balloon angioplasty, endovascular stenting. Now, if the child, prior to surgery, we could use drugs. If it was identified early and it was repaired, it could mean the cure. But for those who have stayed long and end organ damages have occurred, we will need continuous therapy. And as for the choice, my chief just made a brilliant presentation, and we brought up the fact that we have gaps in choice. But however, we know that African American children generally do not show robust response to angiotensin converting enzyme inhibitors. So calcium channel blockers appear to be better for them. So we would consider calcium channel blockers in that category. I don't know. The next question, please.
Yeah, sorry, this question is clearer here. It says, why is ACE inhibitor contraindicated in stage 4 and 5 renal failure?
Okay.
Yes.
Okay. Yeah, it's all right. So, well, I know the effect. So I know it's we talked about in children with hypertension and chronic kidney disease, proteinuria, DM. We could use, but that is those are end stage renal disease where the efferent arteriolar effects are known to worsen the pathology. So in such situations, it is recommended that other drugs are used. But I think our nephrologists in the house could throw more light. But I'm talking about efferent arteriolar effect of these drugs in end-stage renal disease contraindicated.
Okay, thank you very much. A question for Professor Chinawa.
Hello? Hello? I can't hear you from my end. Hello?
Hello? Yes, sir.
Yeah, I can
I'm
hear you
back now.
now. Go ahead.
The etiologic pattern of hypertension in children shows that more than 95% is
Yeah.
renovascular and renal parenchymal disease. Don't you think that pediatric nephrology should take the forefront in filling the gaps that you discussed?
Well, it's a very important question. If you look at our first slide by Peter Egoche, he clearly defined hypertension, blood pressure as cardiac output and heart rate. So peripheral resistance, sorry. So you can see that the major thing here is the cardiac output. So when you have all these issues about renal issues on nephrology came up in Can you hear me?
We can't hear you, sir.
Hello?
Yes, we can hear you now.
Can you hear me there?
We can hear you now.
Yeah. So I said majority of the issues of end up to an ab initio anomalies of the cardiac output. Dysfunction. What happens first is there will be a kind of dysfunction of the cardiac musculature and even the cardiac output and also the cardiac function. And when that happens, there will be others begin to have issues like kidneys, even other vessels, and so on and so forth. So the answer is yes, but don't forget that the primer of this cardiac renal disease is a standby or an initial cardiovascular disorder. Thank you.
Thank you, sir. And then there's also a question here on the fact that knowing that most of the children we see in the hospital are anxious, how many times do you suggest to measure the blood pressure before diagnosis of hypertension is made? I think this is also for Dr. Egoche, but Professor Chinawa can also shed light on this question and any other questions that we have asked on that has been asked so far. Hello.
Okay, so maybe I would talk then, my chief can. So from the guidelines, fifth report, the guidelines, they said that, yeah, so it's a challenge in children, but it's expected that the child sits quietly in the consulting room with legs on the floor uncrossed and calm for 3 to 5 minutes, and with the mercury sphere at the level of the heart. Now, you see that this will take a lot. Measurements initially by palpation before auscultation, and we take 2 to 3 readings and take the average. Now, this is what is the standard. As to how we can achieve that depends on our skill in how we can calm down these children, but the standard is what it is.
Thank you very much. Other questions here still for you. What blood pressure cuff is ideal for measuring blood pressure in neonates? And then there is one on does coarctation of the aorta affect the choice of arm the blood pressure should be measured? Secondly, does the concept of normative data formation affect the arm to be used in blood pressure measurement? Those 2 questions for you, Dr. Egoche.
Okay.
Is it meant for me? Okay, sorry.
Oh, okay. Thank you, sir. Okay. So, appropriate cough, again, that is obviously another challenge in the management, which has been handled. Now, appropriate cough, the definition remains what it is, that the bladder length is at least 80% of the mid-arm circumference, and the bladder width at least 40%. So as to whether we have it available, it varies depending on the center, but that is the definition of appropriate cough in pediatrics. As regards adults, where we have literally uniform cough for everybody. Does coarctation of aorta affect the choice of arm where the blood pressure? We, in answer to the earlier question that asked which arm, conventionally left. The point is that the pressure will be less distally. That's the arm, sorry, the pressure measurement from the legs will be less than that of the arm, and the diagnosis is made. As to choice, left arm generally for blood pressure as a whole, while the lower limb. So does the choice of the arm affect? Secondly, does the concept of numeric data affect the arm? Well, I think my chief could answer this, but this is what I work out of it. Blood pressure measurement, standardized arm, usually left, reproducible. I think that's what I have for that. Thank you.
Thank you very much. Prof, sir, anything to add to that on the concept of normative data formation affecting the arm to be used for blood pressure measurement? So there is a question here
from first level.
Okay.
Okay. Wait for the question.
Hello, sir.
Can you go on with the question? Sorry.
Okay.
Yeah, I'm hearing you, please.
There's a question on how do you diagnose renal artery stenosis clinically when you cannot auscultate a brew?
Well, the bona prima here is that brew on auscultation. But you also have to look at it epidemiologically. That the child that the unit I saw that have been crying excessively right from the 5th day of life. If you do apart from clinical examination of the brew, or maybe palpating the kidneys by examination, which may not even be clear for newborns, you must have a very high index of suspicion. What I did, I told myself no fever. I took a very good, take a very good parental history, take a thorough history. You will see that at the end of the day, because the mother was hypertensive. You get the point now. I think the mother, he even had preeclampsia or something like that. I could remember again. So we have to find out. They just do a thorough examination and we'll place our weight on CVS examination and we started measuring, took the pulse, went straight to our cough, pediatric coughs. It's good for hospitals to have newborn and pediatric coughs. Immediately we checked that it was very high, and with that we sent for renal ultrasound, Doppler ultrasound. Thank you very much. So the key word here is high index suspicion for our own setting. Thank you.
Thank you very much. So the high index of suspicion with the Doppler ultrasound and also will help with that diagnosis.
Good history.
A question for Dr. Igoche. Is there a reason why systolic blood pressure in the lower limb is higher than the upper limb in children, whereas the reverse is the case in adults?
Okay, we talked about the concept of peripheral amplification of the systolic blood pressure, which does not affect the diastolic blood pressure, nor does it affect the mean arterial pressure. So it's the peripheral amplification, yes. Now, but for adults, it's not so, because in pediatrics, the elasticity of the vessel. So the reason why it does not affect adults is that in adulthood, the vessels are not as elastic, again, as it is in pediatrics. So whereas peripheral amplification of systolic blood pressure is that it is a known phenomenon in children, it's not so for adults.
Thank you.
And again, let me just add to what Peter had just said.
Yes,
that's what it is called developmental and malfunctional angiogenesis, which explains what Peter just mentioned now. that as one ages, the vessel thickens in a reverse manner. So that can also explain that particular question. Thank you.
Thank you, sir. So there's a clarification here on the question asked on ACE inhibitors. They are contraindicated in AKI and AGN, but not in CKD. ACE inhibitors reduces the GFR due to its effect on constriction of the efferent arterioles and therefore worsens the AKI. So that's why it's contraindicated in AKI and in AGN. There's also a question on for Dr. Peter. Can you please summarize stepwise management of an 8-year-old child seen with persistent hypertension in clinic after lifestyle modification has been done?
Okay, thank you. So primarily that 8-year-old child, it's assumed that the child had the risk factors such as obesity, and that is why lifestyle modification was done. When lifestyle modification fails, pharmacological therapy comes into play. But we are supposed to also differentiate furthermore whether it is primary or secondary. We assume that that 8-year-old is possibly still pre-pubertal. So, and we said that in differentiating between primary hypertension and secondary hypertension, you know that for pre-pubertal children, usually you think of a secondary hypertension. So our minds will quickly go to secondary hypertension to identify what possibly is causing it. Whereas we know that after failure of lifestyle modification, it will be drug therapy. But then looking for the diagnostic workup for what the secondary cause would be, which we ran through from history, physical examination, then trying to cone down to specialized investigations like doing echo for end-organ damage, doing ultrasound to rule out renal vein thrombosis. So those ones are done, and to the specialized chemistries we talked about. So it opens up a barrage of investigations for that child that has failed, but therapy starts because lifestyle modification has failed. And we said we may possibly want to commence with calcium channel blockers, but then the ARBs and ACE inhibitors are still necessary. Thank you.
Thank you very much. There are 2 questions here. I think this can go to any of the presenters. The central chart for interpreting the blood pressure in children is developed using the right arm blood pressure values. Will this affect the choice of arm in children as compared with adults that don't require central for interpretation? And there's another one here on, can folding a blood pressure cuff affect blood pressure values? How long do we take blood pressure in children to make a diagnosis of high blood pressure? Any of the presenters, please, can answer this question.
Let me answer the first one. I leave the second one for Peter. What you said is quite correct, but you see, for us to prove it, it's like you raised a hypothetical question that will require some studies to document and prove it in our own local. That's what I'm talking about, this gap. You see, what you said, you have raised a question, I'll call it a research question or a hypothetical question that requires further research to establish the answer. Thank you. But if I tell you yes and give you reasons for yes, research may even disprove it. So we have a lot of work to do in our association. Thank you very much.
Thank you, sir.
Peter? Okay, thank you. Folding of BP cuff and the values we get, it is we should have standard cuff, and anything below the standard will affect the readings. So yes, can folding affect it? So that may be the next option we have, which is unfortunate, but it is not what it's supposed to be. How long do we take blood pressure in children to make a diagnosis of hypertension? Well, when we looked at the evaluation at presentation, we said that There are some that you want to identify in whom you want to commence therapy almost immediately. If I meet a child for the first time, if we meet the child for the first time, and there is hypertension that is already stage 2, you would want, and symptomatic, you would want to commence treatment almost immediately, and pharmacological treatment almost immediately. But as to how long you will check, we may have that leeway for elevated blood pressure or for stage 1 hypertension, where we have time to counsel on lifestyle factors. You may want to check like a week apart. But that answer depends on, well, the severity at the point you made that diagnosis. Hoping that the technique was right and we measured at least 2-3 values and took the average.
Can I come in here?
Yes, sir.
Can I come in here, please? Yeah, thank you, Peter, for that wonderful answer. But you see, folding of cough is not acceptable. It's not ideal. That's why we should make effort to get the available coughs for different ages. They are readily available in this country, so that every clinic must have coughs for neonatal, for preschools, schools, adolescents, obese. And that is, you have to, because there's an inverse correlation between cough sizes and blood pressure. There's an inverse correlation. So folding of cough may not be the best.
Thank you very much, sir, for that comment. This brings me to the comment here on the platform. There's one that from Dr. Abdullahi. Good day, everyone. A big thanks to PAN and all pediatricians across the board. However, I want to suggest that PAN should use this avenue in procurement process to ensure basic and friendly working tools are ensured or available from primary to tertiary institutions in the country. You would hardly get appropriate size coughs in more than 90% of Nigerian healthcare facilities. I hope the vulnerable groups are not going to be marginalized from basic working tools and equipment plus drugs for optimum pediatric care in Nigeria. Thank you. I think these comments will be addressed by the PAN president-elect when she speaks. There is also a comment here on thank you for the presentations. I wish the presenters were given more time. We appear to rush over it. Are the slides going to be made available, especially those for the choice of medications? Thank you for that comment. The presenters had 20 minutes each, but I'm sure that the slides will be made available. We can to all of us here. There's one question also on which is the best screening tool to be used for school children, oscillometric, aneroid, or mercury sfigs. So I think first Dr. iECHO addressed this, but yes, sir,
okay.
You can go ahead with that.
Okay. The best method of blood pressure in adolescents, according to World Health Organization, is the auscultatory mercury manual technique, which is a signal meter oscilloscope to the corridor of sounds, making it a gold standard. However, for you to use a oscillometric method, it should be validated and generally made acceptable for pediatric use. Thank you. Peter, you can add to the answer, please.
No, thank you, sir. I think it is what it is. Very clear, sir. Thank you.
Thank you. Yes, still a few more questions. I think we'll take this last round of questions. There's one here on what do we say about the preference of right arm to avoid false low reading in children with coarctation of the aorta if measured on the left? That is one. There is also a comment here on folded coughs. Folded cough increases the compression pressure and would lead to wrong readings, and so it is not acceptable. Another question, please, every child with persistent hypertension must have a dipstick urinalysis done to rule out kidney disease. Okay, this is a comment, which is a common cause of hypertension in children. So yeah, so we'll take the last question. What do we say about the preference of right arm to avoid false low reading in children with coarctation if measured on the left?
Okay, thank you.
Can you come again, please?
Okay.
Okay, go ahead, Peter. Yeah.
Okay, the question is asking what to say about the
Go ahead, please.
Okay, yes. Okay, thank you, sir. So we said actually blood pressure measurements, I think because we identified that the presentation was actually a rapid presentation, we should measure left arm, right arm, measure lower limb blood pressures. Now, by the time we get the difference, the reversal in peripheral amplification in children who are suspecting coarctation, obviously it means that the right and the left arm will differ, meaning that left will technically be less than, possibly less than that of the right. We had answered earlier in this question when the similar question came that both arms should be measured, and when we get a value greater than 10 millimeter mercury on any of the arms, we use that one consistently for a follow-up monitoring of the child. So I think that takes care of that.
Can I come in again, please? Can I just
Yes, sir.
Okay, thank you. Peter, thank you for that wonderful answer. Just a little addition to what I've already said to build it. You know, in aortic coarctation, the blood pressure is typically measured in the right arm because the narrowing of the aorta carries blood to the blood. It's located after the origin of the branchiocephalic artery, which branches off to supply the right arm, head, and brain. So that issue there is the location, I'm talking of the coarctation of the aorta, which is normally found at the right part, and the narrowing, which gives rise to the right branchiocephalic artery, branching to the head, to the arm, and to the brain. Thank you very much.
Thank you very much to our presenters for these very insightful and educating presentations. We have exhausted all the questions on the chat box, and we have also looked at the comments raised. The last comment here talks about the fact that renovascular hypertension constitutes 90% of hypertension in children, which therefore underscores the need for a renal evaluation in all children with hypertension, which is well noted and very true. So we thank you all for your active participation in this presentation. If there are no further questions or comments, I hand over to the PAN President-elect, and I please remind her to make a comment on the comment on the comment that was raised earlier about how PAN can come in the management of hypertension in children. Thank you.
Thank you so much, able moderator. I told you we'll have a great time. I'm sure our daughters are filled because this is something that a lot of pediatricians are not too familiar with. So that's great talk. Thank you to the moderator and for everybody for listening till now. On how PAN can help, please come to PANCOF 2026 Gateway, Abeokuta. Then you will see how PAN will help there. Not only PAN, but NISOPAC. But that's a good point raised, and it's really something to look into because it's a challenge, even in my own institution. So on that note, I want to say thank you to everybody for attending this webinar. Thank you to NISOPAC. Our elders have been here at the point. It was the attendance was so high, over 180 at a point. So thank you very much, man. And let's have a nice evening. If you can come to Port Harcourt, please come to my house for my birthday. Good night, everyone.
Happy birthday again. Thank you very much.
Thank you.
Happy birthday to you once again.